Hello, everyone. I'm Kevin Kunze, Managing Editor of HCP Live, and here today with another remote video interview as part of our ongoing COVID-19 series coverage. I'm joined today by Dr. Jay Bhatt. Dr. Bhatt is an internist in Chicago and Aspen Health Innovator and the former Chief Medical Officer of the American Hospital Association. And Dr. Bhatt is qualified more so than most to discuss today's topic, which is the concerning disparities that we see in COVID-19 affliction as of the most recent data that we're working with here in early May. And before we get into all that, Dr. Bhatt, would you just want to say hi to everyone?
Sure. Thanks so much, Kevin, for having me on today, and really appreciate the opportunity to be in conversation with you and share some thoughts with your audience.
Absolutely, and we're very glad to have you. And this is actually something that's been arresting some of my conversation that I've had at least in the last week regarding COVID, which is again these concerning disparities that we're seeing in patient populations, speaking specifically to demographics and race. Dr. Bhatt, could you give us a layout a little bit of what exactly the definitions of these disparities are right now?
So what we're seeing is that there's differences in health outcomes, severity of disease, number of cases that are positive, and disproportionately that people of color are affected by this condition. And when we look at particular areas of the country, certainly in Chicago, where I live, more than 70% of the virus-related fatalities were among African Americans. And we've seen this in level of challenge in New York and in Detroit and other cities around the country. And even in Georgia recently, there was significant concern about the numbers there. And so I think, given that COVID-19 has really just illuminated the health inequities that have existed in our country for a long time, and I frame it as health inequities is America's chronic condition, that we've been putting Band-Aids on this issue for so long and haven't driven forward policy systems and environmental changes that are meaningful and sustainable for the long term.
Right. And the way that, I was speaking with a researcher this week from Johns Hopkins about this exact issue, and something I brought up that I've noticed in even, conference discussions or presentations of, health disparities among races and ethnicities in the country is the cyclical nature of those who are stuck in this issue. And I think you even mentioned it in your initial email to us, the fact that it's also a food shortage concern. It's also just other perpetuating facets, pillars of health that are burdened more so on top of increased risk of disease and disease severity, right?
Yeah, absolutely. So what creates exacerbating conditions for this illness is also the social needs that people have, the social determinants like food insecurity, transportation challenges, housing, access to affordable housing, isolation, which we know, loneliness contributing to poor health outcomes, as well as the notion of multi-generational housing and crowded housing. So that, there are social needs that we're trying to help connect people to help them make it through particular health challenges they have. And then there are this notion of social determinants, which is much more broader. And then I would say the third part of this is health equity and systemic issues, which are generational policies that have perpetuated situations in neighborhoods for a long time. And this is evident in recent data that just came out, where a group of researchers looked at the census and saw that in counties that had more than 13% African American, compared to those counties that didn't have that level of African American residents, there was 60% deaths in those counties where there were higher than 13% African Americans residing there, as well as 50% more cases. So all of these issues are creating a perfect storm that's lifting up the disparities we're seeing. And I would say that there's also evidence around chronic stress, poverty, discrimination that impact health outcomes, coronary artery disease leading to heart attack, elevated blood pressure. And then there's something really interesting about how this virus might work that folks have been pointing to. And it hasn't necessarily completely been studied effectively enough, but it's something to think about. So there's the angiotensin converting enzyme receptors on which the virus enters the cell through. Now, we typically take medicines that inhibit that enzyme to help address blood pressure and kidney disease, particularly in African Americans and people of color. And now, if those enzymes are being proliferated at a higher rate and not inhibited, it further exacerbates those conditions. And there's nitric oxide, a gas that potentially blocks the virus's attachment to those receptors on that enzyme, which can be helpful, and it's underrepresented and deficient in African Americans. So there's, some of these other things we're trying to learn about as this is a new condition and a lot to understand.
Yeah, certainly. There's just a lot to still interpret and, I guess exactly understand from what we knew about it even back in March in terms of how we believed it manifested, or the most common symptoms has evolved already. So of course, I think how it affects different demographics is going to be very critical to learn going forward. And I think one of the most advancing facets of research that we have going on here beyond diagnostics has been the pursuit of vaccine candidates. And obviously it's a low success rate for a lot of trials, but there's still the ambition of go ahead and trying to see if we can find something. Obviously, with recruitment starting in the US now, could you stress to us the importance of having every demographic represented in vaccination assessment, at least in terms of collecting more information of the disparities?
Yeah, I think it's absolutely critical, Kevin. I think that we need to understand as much as we can about this condition and how it impacts people and what treatments and vaccinations can be effective. And I think we need to do that across demographics because we're seeing differences now about how this is showing up in people. And so I think that both in the ways that we're learning and treating and trying to drive forward preventive measures, the more we do now, the better we'll be off through subsequent waves that might ensue. And I think there's 14 different vaccine candidates in play. And I think that there's important investments that need to be made in that kind of work and testing so we get development of vaccines that work for everyone. And we know that in the recent CARES Act, there was some investment of dollars for the NIH, I think less than 0.05% of the total. But I think we need to double down and invest more resources in trying to help advance vaccine and treatment development. I think that we're talking about vaccines here, but we also got to think about testing. I've been in environments, certainly in the community, where I see patients and other places where there's underserved populations where they don't have access to testing, in the same way that others may. And that's both diagnostic and antibody testing. There are folks that are afraid, of the cost it might end up being, and also the potential that they may be exposed and get sick if they go to care settings. So we're also seeing challenges with chronic disease. Are folks gonna come in later with this wave because the prevalence of heart disease and stroke and abdominal pain hasn't necessarily changed, but we're seeing less of that, in the emergency room or hospital settings.